just give it a few minutes. Welcome to the webinar. I see everybody's joining online now, so I'm just going to give it 1 minute, make sure everybody's online before we begin. Okay, looks like people are popping in. So welcome, everybody. Thank you for joining us today for our webinar, for our discussion, online discussion and webinar about telehealth and looking beyond COVID. Today's presenters, I'm going to introduce to you is Tom Foley, the Vice President of Growth here at AMD Global Telemedicine, and Brett Stover, the Chief Executive Officer at Oklahoma State University. Just a few things to keep in mind as we're going through the webinar. We will be taking questions at the end, so feel free to type in your questions along the way into the bottom, the Q&A session screen, and we'll go through as many as we can at the end. Also, the whole webinar will be recorded, and everybody registered for the webinar today will receive a link to the recording by tomorrow morning for the webinar. I'm going to hand it over to you, Tom.
Awesome. Thank you, Carrie. And thank you, Brett, for joining us in this discussion. As Carrie said, my name is Tom Foley. I'm the VP of Growth here at AMD Global Telemedicine, and looking forward to speaking with everyone today about looking beyond COVID. And with that, I will advance the slides. So the COVID impact. COVID has done, the unfortunate thing about COVID is obviously the impact to our residents or the entire community. However, it has taught us a lot of different things around our delivery care infrastructure. And so I want to take a look at what we were doing actually before COVID, as well as what COVID taught us and how that advancement of COVID really does accelerate the reimagination of a delivery of care model. So the good news is that COVID before COVID, telehealth was really a nice to have platform. Now it's almost a must have. And we have some very interesting statistics from both the consumer side of the equation and the physician side of the equation that says, yeah, this is good. I like this, and let's keep using it. And the facilitator of that really has to do with some very quick decision making from our CMS partners, in that they really changed the policies quickly to be able to adapt to the challenges that our delivery of care infrastructure was having relative to engaging patients and the providers. So, changing the originating site and making telehealth a billable event where it might not have been so broadly adopted in the past, but ultimately their policy changes, as well as the adoption of telehealth, has really changed the way in which we are looking at the delivery of care. With that, so what are those impacts? So obviously, with the onset of COVID, nothing that you don't already know, in that it was difficult for providers and patients to have an engagement. So doing that video only type of engagement was kind of a mandatory thing if in fact patients were going to be able to see their providers. And why is that? And obviously what COVID has taught us is, coming into the waiting room with a contagious condition, whether it be a cold, the flu, or something else, it really just wasn't the right thing to do anymore. And that's one of the major learnings. And the patients themselves get it now in the context of, how what they do could spread. And so how do we go about mitigating that as we move forward? So telehealth is not just a COVID fad. It is something that's going to be embraced across the delivery of care. for a long time to come. So when we look at the, how we move past COVID and what we might be seeing is, even in hospital settings, it's not just about patients going into the waiting room and mitigating and social distancing and things of that nature. It's about how can doctors engage patients at the bedside. Maybe they're not necessarily at the bedside 100% of the time. Maybe the doctor comes to them through a video encounter and allowing maybe greater efficiency of the provider, but yet still providing that same quality of care. And then it's the how do we so with that, what has also happened during COVID is a lot of patients really just haven't engaged healthcare, and so they put off what doesn't hurt them. But whether it be screenings and management of chronic conditions and things of that nature. So it was too hard to do, or decided not to do because they didn't want to take the risk of going someplace to have that potential exposure. So we will see as we re-engage life here in as it was before COVID, an onset of health systems handling conditions that weren't handled because COVID was such the attention grabber, certainly correctly so, but nonetheless, there's a lot of domino effects relative to the delay of engagement and management of conditions. So with that, when we look at pre-COVID and even post-COVID, we see a significant challenge relative to just number of physicians being available to provide care. And not only is it the number of physicians, the larger macro trends here is that, again, before COVID, things that we were trying to deal with is that we had a growing population. We had an aging population. We had a population contracting more and more chronic conditions. And they were still challenged with having less doctors and nurses available to deliver care. Those two things don't sync. And that's the reason why, when we ultimately do need to reimagine care. Because if you have a larger population, a sicker population, and an aging population, and with less doctors and nurses, how do you deliver the same quality of care? Sometimes it's not always about going to the doctor. It's about being seen by the doctor and having that same level of quality encounter that you once had if you were going to that brick and mortar facility. So with that, it's not even about a video encounter. So let me just go through a couple things. In that, again, when COVID hit, the immediate response was to do something, rightfully so. Get something in place so I can engage my patients and some patients can engage me relative to that delivery of care. And normally that has been just a video only type of engagement, and that was the right thing to do. But now, because once we've moved from telehealth being a nice to have to a must have, and now we're experiencing the value of telehealth and ultimately re-engaging in, well, how do we deal with the challenges that we were trying to deal with before COVID? It's a matter of, COVID did for the delivery, what COVID did in 8 months relative to the impact to the nation. It advanced healthcare 8 to 10 years because now because it fast forwarded the idea of the value of what telehealth can bring to the table. And it's not just about a video encounter. It's if we merge the two, older, aging, sicker population with less doctors and population health, and leveraging, geez, how can we and all the learnings of COVID, how can we reimagine the delivery of care? I'm not saying, for clarity, telehealth is going to be the tool used for 100% of engagements. I'm not. it has its right place. But it's the merger of the two that really really again allow us to reimagine the delivery of care. So I'll go through a couple constructs as to what I mean by it's not just about video, and then we'll engage Brett in a conversation on those points. So so it's really, when we look at the health system, the people, the patients are really at that center of that health system.
Tom, before you move on,
My slides have a timer on it. Apologize for that.
Tom.
So the people are at the center of that health system, but the health system, when you look at that patient, their origins come from many different places, or the setting of care is more than just the acute setting. So when you look at the home, the ambulatory settings, even EMS, long-term care, corrections, schools, employers, these are all folks that all need some constructs of care. And that health system really becomes that hub of the community. And so when we look at telehealth, it's really about how does one platform service all those different constituents and be able to be dynamically configured, if you will, to address the unique workflows and engagement models. And if you're wondering why there's these different points, it's not only about a telehealth platform that is servicing one health system, one facility at one location. It's really about for whether you're an IDN or I live in Florida, so whether you're the state of Florida and you're looking to provide services across your state. It's really one platform that services multiple facilities in a very unique way. Every facility might have a different way of doing things, and how do we ultimately manage that through a telehealth platform?
Tom, can you hear me?
I can.
I just want to launch that first poll we had for what phase of healthcare system
Awesome.
the attendees are in. So I just, if you could please answer the question, what phase of healthcare? What phase is your healthcare system in? Sorry, there's a typo there. Respond, recover, or reimagine. Give it a few minutes for attendees to populate their answers. Could play music.
Little background music.
All right, we got about half the attendees so far have voted, so just give it a few more minutes. So far, I think the results are up. I think everybody can see it, but maybe not. So I'll wait to the end. But right now, it looks like respond is where about 53% are currently. Reimagine is right behind that at 39%. All right, I'll go ahead and post the
Awesome.
Share the results so you can see. Everybody should be able to see. Respond came in about 53%, recover 9%, and reimagine 38%. So that's good.
That's very good. Awesome. Okay. So continuing on. So when we look at telehealth, we look at a telehealth platform. We look at certain pillars that are necessary for success. And again, when I said it's not just about a video encounter, it's really about a telehealth platform that can service the health system across multiple use cases, and being able to integrate with that EHR. And so not only that, the ability, again, not just to have a video encounter, but how do you handle the different types of engagement, and async engagement, I'll go through that in a second, versus asynchronous engagement. And ultimately, if it was important to manage, or if it was important to take vitals while you were in that brick and mortar facility to have a quality engagement, it's equally important to have to capture those vitals when in a virtual setting. Not that, again, you need to capture vitals for all engagement models, but it is critical relative to telehealth, moving beyond a video world to a full quality, high acuity encounter. So seamless medical device integration is a critical key to all that. And as you can see in this image, there's several different medical devices, whether they're used in an acute care setting, an ambulatory setting, or the home. The device necessary for that type of care delivery is important. So being able to dynamically interchange the devices in the context of a visit or in the context of the delivery of care model for that unique patient is very critical. So as that home becomes the setting of care, so does the mindset of, well, all right, well, what type of devices do I need potentially in that home to maximize the engagement, maximize the quality of care, and allow that patient to ultimately even construct some self-monitoring efforts as they move along that continuum from awareness of their condition to wellness of their condition. So so how do you do that, right? Each patient, each engagement, that digital front door. How do I access the health system, and how do I handle a school-based encounter versus a corrections encounter versus an EMS encounter, and so forth and so on. Having a protocol designer that you can actually use. You don't need us or anyone else to actually create these protocols. Your health system can create these protocols and very easily adapt them to that unique use case. So this is what allows, as I was saying earlier, one platform to be able to be adaptive to the different use cases that you might have across your settings of care. These are things that you manage, not your telehealth vendor, if you will. We're a tool, we're a tool that helps you maximize your ability to engage your patients through one platform across multiple settings.
And Tom, we have the other poll question about unified engagement. I just launched the poll question. How important is seamless medical device integration to your organization's telehealth strategy? So go ahead and attendees can enter in their response. We'll wait a few minutes for that. It's still going, but so far very important is 77%. I'll just let it go a few more minutes. Okay, and I'll share the results. So 76% is very important, 20% somewhat important, and I think it's clear medical device integration is very important.
Awesome. Okay, I believe I have one more slide to go through, and then we'll get into a one-on-one with Brett, and he can share with us his insights. So we look at this. Scenario. I talked about async engagements. Sorry about that. We look at this async engagements, and we look at, I'm going to fight with my slide here. I'm sorry. So ultimately, it's about async engagement to video engagement, and then from along that async vertical, there's a number of things you could do versus what you could do in a video engagement. And so what I'm trying to say here is that there's really no device integration taking place here, and the patient is really engaging in an offline manner all the way through having a video engagement. So let me give you some examples there. So I could go to the digital front door of the health system. I could register for an urgent, quote unquote, urgent complaint. I can list out what that complaint is. It goes into a queue, and the provider may look at that complaint and say, "Yeah, I get it. I just sent a prescription over to your local pharmacy, and and here's the information." Or the provider can say, "Hey, I get it. Let's schedule a video encounter. Let me talk to you about a couple things," and then have that video encounter. Right? That's a low acuity encounter. No devices required. But then you have, we hear a lot about remote patient monitoring. I might rephrase that and say it's really a monitoring service. Depending on the device that could be prescribed to a patient, they could perform self-assessments, and that data flows to that health system, whether it be an ambulatory EHR or an acute care EHR. That data flows to that health system. So there's still one longitudinal view of that patient. But it's not necessary for that data to flow. But if they don't want it to, but minimally the patient can take that device and measure their blood pressure, measure their vitals, other vitals, and be able to record that and share that with the health system at the appropriate point. And then you had I'll just use the visiting nurse service as a different example. There's still a monitoring service. There's no physician involved, but a nurse is coming in to the home to take vitals and to assess the current state of that patient's state in relative to whatever condition that they might be managing. But then you could also move into, if there's a need for escalation in a monitoring stage, you could escalate that into an urgent high acuity encounter where the provider is actually engaged. So here you have the patient with a medical device that moves into a video engagement, and that device. So yeah, you did capture vitals prior to the video engagement, but the doctor might say, "Hey, let me see those vitals again," and in real time, that data streams from that device to the provider. And whether that device is capturing data per se, whether it's a stethoscope and that data is flowing directly to the provider's ears across the internet, or whether it's capturing images, it's an otoscope. You took a picture of your ear, the nose, the throat, in a directed way from the provider, and that all that information is captured in real time and being able to seen by the provider. And then that is what we would refer to as a high acuity encounter. And the same thing holds true if you have a nurse in that home or at that setting of care where they're escalating. The same thing holds true. The difference here is that obviously the patient isn't doing the assessment. The doctor is instructing the nurse or the practitioner to engage and move accordingly. So this is really the only commercial that you get from me from an AMD perspective, in that that's really the difference between a video only scenario that you might have adopted in the context of Respond versus reimagining the current state of care. So a telehealth platform that can address all of that is really what allows you to maximize a single platform across your health system that uniquely addresses the different needs of your patient base, coupled with obviously a device portfolio that can help you achieve that. So it's a video and devices coupled with the flow of data that ultimately drives how telehealth, virtual care delivery, more importantly, will be used in the months and years ahead.
Okay, we have one more poll question, Tom. I just launched it. What services are most important to organizations' business goals and virtual care strategy? So low acuity encounters, monitoring services, high acuity encounters, or all of the above. I'll give it a few minutes again. Interestingly enough, so far, and I'll launch it when it's done, but 72% are saying all of the above, which is great. That means they're looking to scale.
Yeah, and that really tells me, that's really the proper use of telehealth. And there's a lot of different uses. Again, it's the ability for a telehealth platform to scale. I ultimately relate it to patient portals to some degree, believe it or not. Multiple EHRs within the health system means potentially multiple patient portals. You really can't ask the patient to go to multiple patient portals to access their health records. So the same thing holds true with telehealth, in that having multiple telehealth platforms within one health system creates usability challenges and engagement challenges of, this condition, that this model of care, this telehealth platform. And I use this device, that means I have to use this telehealth platform. And it just becomes very costly and doesn't, in my view, doesn't do much in context of maximizing that patient's engagement.
The results, I shared them here. So again, it's 74% are saying all of the above. And then 17% are just saying low acuity, 5% monitoring services, and 5% high acuity.
Awesome. So with that, we can move into our one-on-one. Let me just advance the slides here. So Rhett, I appreciate your spending the time to join us in this conversation. Thought we might just kick it off by, your Oklahoma State University of Medicine is in the trenches relative to COVID. And so tell us a little bit about your perspective of where you're at, what your system's doing, and some of the learnings you have.
Yes, thank you, Tom. Happy to do so. Good morning, everyone. So, it's been interesting just hearing some of the observations that you've offered this morning, and in anticipation of spending some time with the group. I think it is important that, as much as we can, that we maintain an amount of reflection as the advancement of telemedicine is still moving at an incredible pace across many markets, across the country. And I'm happy to share a little bit about our experience in Oklahoma with OSU. So just for benefit of the group, OSU Medicine's an academic integrated healthcare delivery network, primarily focused in Northeast Oklahoma. We have our academic health center, teaching hospital is located downtown Tulsa. And then we have a network of roughly 600 adjunct and clinical faculty spread across the state. And telemedicine for us has always been, Tom, I think you mentioned it as a nice to have. Many systems treated it as such. It was a nice to have. It was something that was, really viewed as either a convenience or complementary to something else that was more, that was treated more like a core competency. And there were, for us, a variety of reasons for that. But ultimately what it meant for us is that there was this inconsistent amount of urgency around solidifying telemedicine as a core competency, or as a key modality in the way that we organize care across our communities. And so we kind of brought that history, that mindset into 2020. It was kind of, the beginning of 2020 was business as usual. And then of course, everything changed in March and April, and that set the course for us. That set us down a course of really forever changing the way that we have organized, orchestrated, and established our healthcare delivery system.
Interesting. And how do you see the meshing, if you will, of the classic care delivery model with the insurgence and the integration of a virtual care delivery model?
Yeah, I think that's a great question. We're still, we're collecting evidence on that based on our experience, and there's still some variety. There's some variation. So, in our experience in Oklahoma, what we had the opportunity to do through our relationship with the state and our commitment and experience in rural markets across the state, we were asked to scale a hospitalist program immediately, from the standpoint of technology procurement and acquisition, getting it to each of the markets, and then having the clinical bandwidth and expertise to provide a hospitalist service in the middle of a pandemic, and all the adrenaline and uncertainty and to some degree excitement that all of those activities brought with it. And our experience thus far has portions of it have been really consistent with some of the market-based research that you've presented. I think a couple of things that I would kind of highlight are many of the rural markets that we were routinely engaged with were also routinely reluctant to embrace telemedicine. Some of that because of lack of physician understanding, commitment, or maybe just a cultural characteristic of the medical staff in that community was that they just hadn't given telemedicine enough of a look, a credible look, to be taken seriously. And then there's certainly ripple effects that creates in the community. Certain communities, there wasn't enough interest from the patients being served in those communities. So there was a kind of a tie-in because of lack of physician support for the service that served as a little bit of a roadblock for patients to immediately embrace interest in the service, and so that also comes with its own kind of delays and repercussions as it relates to how you approach a community with the idea of legitimizing telemedicine, describing its features and benefits, and helping them understand that not only can their outcomes be protected, their health outcomes, but they can also be enhanced, and really clarifying how we articulate that, the evidence behind it, and what does that mean to their specific experience with telemedicine. And so as COVID came, it took all that away. It wasn't, well, we get time to kind of decide and discern through, do we want to do this or do we not? It was, we have to do this. The time for adoption has already passed, and we've got to we've got to move quickly into this in order to continue to create accessibility, to continue to honor and protect the physician-patient relationship, and to do everything we can to minimize as much as possible any disruption in care, particularly for those who have very compromised immune systems or comorbid conditions, chronic conditions, et cetera, because of the transmissibility of COVID and because of the impact that it's had on populations across our country, but particularly those populations that are already that have a compromised health status. The accessibility to physician expertise and care was really important. So fortunately, in one instance or in one regard, this has helped accelerate the adoption and long-term commitment to telemedicine, and really helped embed in many rural areas across the Oklahoma community and geography. It's really helped solidify telemedicine, so much so that physicians now have made comments to us that, well, this is really the only way that I'm going to be practicing medicine, or I'm only going to do this in a majority capacity for my practice now. I'll never not do telemedicine. And patients have said the same thing. We didn't know how convenient it was going to be. Um, it, uh, in many cases, was described to us that the skepticism that they had was easily overcome by the safety that they felt by having the encounter and not being in a healthcare setting with other patients who may have other ailments, COVID related or otherwise, that would increase their anxiety or concern around their own healthcare needs.
From what you're saying, it sounds as if telehealth has increased the confidence, or maybe that's probably, it sounds well, probably more so increased access to care, right? You have a unique situation, much like some other health systems. You're in a rural setting, so sometimes that mobility of traveling an hour into town, if you will, to get access to care, was always a challenge. So it was easy to defer it. Where now telehealth is, I could do it, frankly, on a moment's notice, if you will, relative to an urgent care encounter. Do you think that telehealth has actually improved access to care in that context for the rural community?
We definitely do. We have 1,000 rural Medicaid beneficiaries that we provide healthcare services for in a variety of ways, and it's a kind of a defined membership model, captive environment, and a majority of the encounters that we have with them are either face-to-face or telephonic. And what we, for that population in particular, routine engagement is really incredibly important because of all of the factors and a few more that you mentioned around obstacles to care, whether that be accessibility, whether it be transportation, or a host of others. Having the ability to usher in an intimate healthcare delivery experience that was very similar to them in terms of a patient-to-patient traditional setting, but just doing it through digital means. I think that the feedback that we received is that they were pleasantly surprised at how warm the interaction felt, and how much confidence they came away with as a result of that interaction in continuing to receive care through that medium.
So it sounds as though your adoption of telehealth is currently in that, what I would refer to as that respond phase, right? I could be wrong there, but you tell me. But how do you see that home transitioning to I won't say a more permanent setting of care, but a more utilized setting of care, using medical devices to support that encounter?
I think that's a great question. I think there's an urban and rural component to that. I think that they each present with their own opportunities and their own challenges, to be quite honest. Some of it is just technology itself. Systems that tend to be more urban focused and have a larger array of resource bases can get those types of technological devices and resources out into the hands of their community or their patients. Their rural counterparts, as a comparison, on occasion struggle to do so with as much regularity, frequency, and in a way that continues to kind of keep up with the advances. And certainly the reason for that is because of cost and access to revenue, or the ability to just acquire the technology in total. So there are two separate lanes to that. Both of them are equally important. Patients in service areas that define urban versus rural certainly are equally deserving And I think the challenge for us is just making sure that we're not prioritizing one front over the other, and and thinking about our obligations. For example, to the state, we have we provide a lot of urban care in the Tulsa metro area, and then equally important in almost in equal amounts, provide a lot of rural care to counties across the state. And so in my opinion, Tom, that question, as relates to more specific kinds of technology devices, that really is an accessibility issue that is cost driven up front, and not the challenge, I would say, is not immediate in terms of clinical availability and access to physician expertise. It's really around resources to get those technology devices in the hands of people that can benefit from them the most.
Yeah, I often say that the discussion has quickly turned from who's going to pay for telehealth to who's going to pay for that device, in the context of again, that reimagining phase. So Brett, take me on a journey, the attendees on a journey. We've learned a lot, and there's still a lot to learn relative to where we're going in the adoption of telehealth. But go 3 years down the road from now, how do you see the delivery of care model changing, given what we've learned and our application of telehealth?
You bet. I'll give you a couple comments. That's a heck of a question. I will give you a few comments just on things that I would describe as kind of ideal. The idea that we get there not remains to be seen, but there's so much opportunity in the advancement of technology. There's so much innovation in the advancement of data. And if you think about the role that telemedicine plays in the future of how care is organized across our industry, in a variety of different settings, I think that telemedicine now gives us the ability to do a couple things. One, meet patients where they are and provide care for them in ways that were yesterday, last month, last week, maybe not completely conceivable. And I think that the adoption will continue to be rapid. I think the advancement around technology and innovation will continue to be rapid. And I think that consumers who historically have been hesitant will now become vocal advocates and insistent upon digital health and features of care, modalities of care that incorporate their interests to receive care in a digital capacity. I think that we'll make clinical advancements. I think that the data that we're gathering around outcomes that are being provided as a result of digital clinical integration is going to be incredibly important. I think the reimbursement journey is going to improve, perhaps not to the degree that many would like, but I do think it will continue to improve. So I think there's a clinical outcomes piece to this, there's an economic piece to this, and then there's a community benefit in terms of total health and population health of communities that telehealth and telemedicine will do as much to advance as anything else that we have in the industry today. So I just think there's a tremendous amount of excitement, enthusiasm for this space, and it's gonna be a critical part of our journey forward in the way that communities receive care.
Awesome. I couldn't agree more. Great thoughts there. Carrie, do we want to open it up for Q&A?
Sure. I will let, we do have one question or a couple questions. Let's see, one question so far I can start with, but just for all attendees, if in case you do have questions for Tom or Rhett, there, again, just click on the Q&A button in the bottom and go ahead and start entering your questions. Tom, I'll start with the first one here. Integrated patient management systems are beginning to be introduced within our healthcare system. Is it important for hospitals to share identical systems when patients are treated across multiple sites?
is it important for hospitals to share the same system across multiple sites? I might take telehealth out of that equation for a second, in context of the EHR, multiple EHRs within a health system or within a community. Take the health system out of it. I think the average health system actually has multiple, even though they might have one major one. So I'm not quite sure technology should play a role in context of how that patient traverses the community of care. However, having a single platform certainly creates predictability on how that patient engages. I go back to my patient portal model, right? How one patient portal works and the features of one patient portal versus another, totally different. But and the same thing should hold true for telehealth. There is advantages to having one platform that a health system would use across multiple facilities, thinking that the health system also had one data platform, population health platform across multiple facilities to advance the delivery of care. I don't know if that answered your question, Brett. Any insights on that from your perspective?
Yeah, I would just briefly add that it's a big, for me, it is a big, emphatic and enthusiastic yes. And here's, and my passion for that is as follows. We have, as an industry, designed digital neighborhoods that are very territorial. And you may be a patient in a system in a rural community, and you've received telemedicine through, I'll just use Mercy as an example. In Oklahoma, Mercy's got a large presence in Oklahoma, both urban and rural, and their telemedicine and telehealth environment is very exclusive to their box, if you will, their sandbox. And there may be specialists in other areas that are close by that could benefit from providing patient care in a rural area that are not either employed or affiliated with a larger system. And because of that, they're not able to participate in that patient's care from the standpoint of being excluded out of the telemedicine digital network. And I think that we've got to get away from that. One of the things that we did in designing our response activities for rural markets that we're serving is our platform is agnostic. So we want to serve the needs of the community, but we don't want to serve the needs of the community based on only the things that we can do. We recognize that there are specialists that may have other arrangements or affiliations with other systems outside of OSU, and we're not going to allow that to be a careless barrier to patients' ability to access care in their communities. We've got to do better and do more, I think, as an industry to make that more inviting. And does that sound Pollyannic and kind of pie in the sky to some? Perhaps, but I am not confused at all about the importance of that, and that's really enhanced by, again, my view that those are careless territory boundaries that prevent patients from being served and prevent their greatest good from being pursued as it relates to healthcare services that are made available in rural areas where they're so difficult to access already. So.
Okay, thank you, Tom and Brett. All right, we have a couple more here. Let's see. What clinical diagnostic tools are on the horizon to integrate with telemedicine carts, similar to handheld cameras, stethoscopes, EKGs, etc., specifically for clinical evaluation during a telemedicine encounter?
I'll take that one first, Brett, if you don't mind. Brett, there's a number of different types of devices that are more that apply a greater degree of simplicity for a consumer to use. And I think that those types of technologies are going to be, um, we'll see an acceleration of those types of technologies as health systems start to look at, well, how do we create or maximize the use of that home as a setting of care? And how do we, and it's not just about having the one-off encounter, it's really for those that have multiple chronic conditions or conditions to mitigate reimbursements or readmittance and or life-threatening illnesses that need monitoring that can be done more so in the house. So I think that there's a plethora of innovation taking place in the medical device arena that will be applicable as we move forward.
Hey, great. All right, this is a really good question.
Rhett, I just want to make sure, any additional insights there?
No, nothing further. I totally agree with your comments on that.
Okay, actually a question around devices and of course the adoption of using devices in telehealth. It says, how do you anticipate handling the megadata generated by global adoption of telehealth devices?
Data is power. And in order to maximize the, I always say that, let me back up. I always use the scenario of the average Medicare patient. Average Medicare patient that has 5 chronic conditions sees 9 different doctors in a given year. And they spend about 15 hours in front of that doctor by stats. The question is, what happens the other 8,745 hours relative to the continuum of care? What happens in that time slot is critical. And if they do have multiple chronic conditions, instead of allowing things to fester, if you will, that data, that self-assessment data can flow. And I do think that there will be, so there's going to be a plethora of data that flows. The question is, how do we handle that data? I don't have any illusions that it's going to be impossible for a person to ultimately be the data miner of that data and to be able to quickly respond to that. There is a layer of AI, artificial intelligence, that can be pursued that it does that interrogation of the data and provides some level of advisory of, hey, that blood pressure, you're on an upward trend. I'd be calling the doctor if I were you, hypothetically, right? Or so that there's not that alert fatigue that takes place that we all talk about. There is a level of technology and innovation that serves as that middle layer that maximizes that patient's understanding actually of what that data was, right? I just took, I had pulse ox, my oxygen levels at 90, right? That's a problem. You should go to the doctor. So it's one thing to collect the data and the patient to understand the data so that they can react. So there's that side of the equation, education on the consumer side. And then there's how does the health system adopt AI and population health management tools that help them sift through that data and prioritize where activity needs to be applied to maximize that care. Rhett, anything on your side?
Yeah, I just think at a very, very high level, it's the combination of the relationship between, the various EMRs and really, we're talking about, some of for purposes, I think perhaps for purposes of the conversation, you're talking about Epic, Cerner and the like. And then you've got, health information exchanges set up across communities and regions across the country. The interoperability between those environments in particular is not as clean as it needs to be, should be. And I think, we'll also see some progress in that regard. I think that and a few other things combined really feed into the artificial intelligence, the data aggregation and the interrogation that you described to help advance the efficacy of clinical decision-making where it is most needed. Not to remove decision-making authority from the physician, but just to further further enhance the integrity and the efficacy of treatment protocols on a disease by disease basis.
Good points.
Okay. Let's see. So another question here. Do you see video patient education content enhancing the patient engagement and the patient experience? And if so, do you see the content helping the provider be more efficient?
I think patient education in and of itself helps the provider be more efficient. I always talk about the awareness to wellness continuum. And the awareness is really about education, whether that education comes in the form of text that one needs to read or videos that one needs to watch. If you're recently diagnosed with diabetes, maybe there's a lot to learn about diabetes, not only the disease in and of itself, but how do you need to change your dietary behaviors and things of that nature, and what are the repercussions of that? So education in and of itself being integrated into the into the flow, the engagement flow is critical. So I sometimes it's important not to prescribe the pill, if you will, but to prescribe information that gets that patient better engaged with care. When a doctor identifies a care plan, the greatest challenge really is around changing the behavior of the patient, and that only comes when they're better educated in the condition that they have and what they need to do versus what the doctor needs to do for them. Again, in that 8,745 hours, that's where the education takes place. That's where the behavioral change takes place. And then they go for this event of an encounter with a provider that says you're on the right track, you're on the wrong track type of scenario, or let's change course here. But yeah, education is key. Red, anything on your side?
No, I agree totally with you. I think it's the balance of it is just kind of information overload and packaging content that is easily digestible and translatable and not intimidating to receive for patients.
Yeah, I might add that it's not only incumbent upon the provider to do the quote unquote prescribing of the educational content, but having platforms available where, and I'm not talking about the internet, frankly, but having platforms available where a patient can go and do a search on credible content, and so that they do want to learn, they have a place to go and learn without giving them a 25-page document to read upon discharge and thinking that they're going to read that whole document and not be seen again within the next 30 days.
We actually were just coming up on the hour, and I know Rhett had a hard stop at noon, so I think we just lost him. Didn't want to interrupt you, but there were a few more questions, Tom. I don't know if you want to address these at the end. They're just they're pretty quick questions, or
sure.
So what is how do we leverage artificial intelligence? And actually, that's not a quick question, but how do we leverage artificial intelligence to improve telehealth clinical encounters?
So there's a couple different ways. So as that data flows, there's a receptor, if you will, in the AI world that I would speak of that says, hey, I got this data. I'm comparing it against the trends of this particular patient. And if you look at Alexa as an example of having someone that can actually speak to the patient that says, hey, as I said before, I just took your blood pressure, I just took your pulse, your heart rate, your oxidation level, you're good, if you will, as opposed, because I always relate things to my 82-year-old mother who had cancer, and she might not know what all those vital numbers mean. So AI is another form of education, frankly, bringing education to the patient and giving them some level of comfort and satisfaction. And it's also a way of further escalating. So there's, I look at AI as that, how do we maximize the clinical decision-making process, both again on the consumer side as well as the provider side of the equation. And again, I might reflect back in life, and when my father was in a rehab, and I don't mean to keep talking about my family history, but I can remember years ago, a big 2-inch textbook or a folder that binder actually that he's flipping through these pages, and I'm like, there's no way he's reading all that stuff. But if you had an AI tool that was able to mine that data, it could provide that greater granularity and specificity towards what is it that we should be doing here.
Okay. Looks like we do have some more questions. I don't know. I think at this point there's only 1 or 2 left. One was just, and then we can end it. I think I'm going to be conscious of everybody's time. I know people have been on for almost an hour now. So the last question here is, how important is it to teach telehealth skills to clinicians to enhance the efficacy of telehealth?
Well, it's very important. And the use of any tool, whether any adoption of technology is the education of that is critical. So, when we saw earlier in the slides that 57% of providers like telehealth and want to use it moving forward, the question is, what happens to the other 43? Is there more education? Do we need to implement simplicity and things of that nature? So it's a key part of any deployment. You can't throw technology at the doctors, at anybody in the delivery of care ecosystem. The training is paramount relative to adoption for both the provider side and the patient side.
Okay. So that concludes our webinar. I just want to reiterate that if you register for the webinar, then you will receive a recording that you can, of course, watch or share with your colleagues, as well as a copy of the slides. You'll receive that email by tomorrow. And if you have any follow-up questions, please feel free to reach out to myself or Tom. We'll include our contact information in the follow-up email. And thank you for attending. And thank you, Tom, for your insights.
Thank you. Thanks, everyone, for attending. Appreciate it.